Vitamin D Beyond Bones. So the reason I was asked to do this, I know it's diabetes, but there's a lot of talk about vitamin D and its potential benefits. So I thought I would just highlight some of the things that I know about vitamin D, because we've been doing a lot of studies in vitamin D. So here's my disclosures again. And I put this up. Sometimes obvious conditions and treatments are the most difficult to grasp. And the problem with vitamin D is that, you know what, it's such a simple kind of, I don't know, physiological thing, and it's such a simple treatment that the problem is there aren't many big pharma companies who are going to push it, and you know, so it just kind of gets forgotten, I think. So the questions that I would like to know are: what are normal levels, right? Does it matter? Does treating it make a difference? And what is the best treatment? Okay, and I'll try and answer those. So you know what, and I think there's a lot of debate about what is normal and what is abnormal. Now, you have a range, and basically it depends if you measure it in nanograms per mil or nanomoles per liter. And that the simple thing is 2.5, you multiply by 2.5. Now, we know that severe deficiency is anything from 0 to 10, and here you'll get rickets, osteomalacia, and you'll get raised PTH. Then you have deficiency, which is 10 to 20, and this is when you might get elevated PTH, but you reduce bone mineral density. Insufficiency, adequacy, which is in my books is 40 to 80, but most people would say actually adequacy is even around 20, 25. So let's just have a look at what I think is, so most people think actually, you know what, if you get a level around 20, 30, it's okay. I believe that it should be higher, right? More likely around 40, 70. And it's based on epidemiological data and the link between vitamin D and cardiovascular disease and cancer that has really driven this higher range. Okay. So what are the causes of people having vitamin D deficiency? So inadequate sunlight exposure is clearly one of them. So UVB radiation, living in the UK, average level is around 16 nanograms. Why? Because we used to live in a high latitude and the UVB light doesn't really penetrate. And actually you need about 4 hours of exposure to good UVB light. In fact, you say that, but then Pakistan, there are studies that show the average level is around 12 nanograms. I don't know, maybe higher, some of the recent studies, because everybody's on vitamin D. Saudi, as low as 4 nanograms. Kuwait, 8 nanograms. So actually, if I do it in Doha, and I do it in Doha, the average level is around 15 nanograms. So it's really very low, despite the fact that we've got lots of sunshine. The other thing that we know can affect vitamin D is increased skin melanin content. So me and you, we're unfortunately at increased risk because we have an endogenous mechanism that stops the conversion of vitamin D with UVB. Age, as you grow older, there's reduced skin 7-dehydrocholesterol, which is required to convert the vitamin D to active forms. Obesity, if you're more overweight, vitamin D can be sequestered in body fat. And then there's a whole load of other conditions which can worsen your vitamin D levels. And the only way you can actually, people say, oh, well, you know, just take it in your diet and get plenty of sunshine. This is the kind of amount of fish that you will need to take every day to actually replace the vitamin D that you need. So we have to think about vitamin D beyond bone. And not only is it the typical, you know, the osteomalacia and the calcium regulation, but there is actually data around cardiovascular disease, around type 1 diabetes, multiple sclerosis, asthma, irritable bowel, and cancer. Because vitamin D actually is affecting not only this and this, but also affecting monocytes, macrophages, and cells and how they divide. Benefits? Well, actually, this is just kind of, you know, other things that I've come across, papers. So the prevalence of headaches may be related with the latitude and a possible role of vitamin D insufficiency. So it's known that as you go further north, the incidence of headache increases. Okay? And people have tried to relate this to various things. What could it be? Is it colder? Is it, I don't know, something that they eat? But one of the things that is kind of maybe got some interest is actually the overall prevalence of headaches and latitude is related to vitamin D levels being lower in these populations. And in fact, there are studies that show that the lower levels of vitamin D, if you replace them, chronic headaches disappear. Diabetes, this is, to me, is an under kind of, not stated because it got published in the Lancet from Finland. And this is, shows you the link between intake of vitamin D and the risk of actually developing type 1 diabetes. So you know, vitamin D modulates like T cells, and so there's clearly a trigger in type 1 diabetes. But if you have, in my book, adequate levels of vitamin D, then your T cell mediated immunity may not be as aggressive as somebody who has a low level of vitamin D. So if you take this population, if they were using vitamin D supplements, none at all, and that was the reference, okay, relative risk, it was 1. If you irregularly used it, then your risk was incidence per you could see was markedly reduced, 33, regularly 24. So your risk of developing type 1 diabetes was actually reduced by, well, 80% if you were taking vitamin D in that population. This is in Finland. And this is actually not from a small study. This was 12,055 women giving birth between 1966 and 1997. And they looked at vitamin D in the first year of life. And then they followed these patients up in terms of their risk of developing type 1 diabetes. This is a Cochrane review, a systematic review actually, a meta-analysis on vitamin D supplementation in early childhood. And what you see actually is some studies show maybe no benefit, but others show benefit in terms of reducing your risk of getting diabetes significantly. You can see by about 25%, 25 to 30% in terms of if you have vitamin D supplementation given in the early years of life. This is a study from Iran, which actually shows the benefits of giving vitamin D on beta cell function. So this is giving 0.25 micrograms 1-alpha twice daily for 6 months. And this is the intervention group, this is the control group, small study, but what you see here is fasting C-peptide levels go up, and in the placebo group they come down, and then again you see here mean insulin dosage, the requirement for mean insulin. So if you are on 1-alpha, you can see the insulin dosage comes down and it goes up, whereas in the placebo group it remains high. In type 2 diabetes or patients who are receiving oral vitamin D and calcium, so not, sulfonylureas or whatever else, or insulin or GLP-1 agonists, just giving oral vitamin D and calcium. I don't believe actually calcium is important, it's the vitamin D that's important. What you see here is vitamin D levels, all subjects is 52, and they were given actually very low doses, what I call homeopathic doses of vitamin D. 400 internationals daily for 3 months. Despite that, you see here, vitamin D levels, this is a study for actually, I think it was from New Zealand, I'm pretty sure. But patients with type 2 diabetes, levels when they started, 15. Afterwards, actually went up, but you can see in terms of the HbA1c, it fell by about 0.5%, simply by giving, and this is actually in nanomoles. Right, not nanograms, nanomoles. So you can see, even there, with 61, what's 60 divided by 2.5? About 30, roughly. But you can see that there's an improvement in HbA1c. In terms of diabetic complications, is there an impact? Well, this is one study in type 1 diabetes, again, looking at renal disease. So if you give if your 25 hydroxyvitamin D is less than 20 nanograms, then you have a much higher risk of developing microalbuminuria. If it's more than 30, you can see it's significantly reduced by about 40%. Just by having adequate levels of vitamin D, you can have a 40% impact on the development of microalbuminuria. And this is actually data from derived from the DCCT. This I just showed you earlier on. Simply by giving vitamin D, you can see that you can improve actually the urine albumin excretion rate and also blood pressure. Cardiovascular disease, Jahani gave a very nice talk on cardiac endpoints and showed how fantastic it is to lower your risk by giving relevant 2B, 3A antagonists, by giving aspirin, statins. But what about vitamin D? Well, there is a link actually between cardiovascular disease, inflammation, the renin-angiotensin axis, and also, as a whole, diabetes and metabolic syndrome and atherosclerosis. And that link is partly mediated by PTH and also by vitamin D deficiency. And in fact, there is data, as you know, that there is with increasing latitude. What happens in terms of cardiovascular events, cardiovascular disease? It's consistent that the IHD death rate per 100,000 population, as you move further north, is increased. And again, people say, well, maybe there's lots of other factors involved. But there is evidence to suggest that this may be related to the levels of vitamin D. And in fact, this is the data that shows you levels of vitamin D. You can see as they go down, the cardiovascular event rate goes up. Independent of cholesterol, independent of blood pressure, you can see that there is an increased risk with the lower levels of vitamin D, nanomoles per liter. And then, again, this is a study a meta-analysis, again shows you that if you compare lowest with the highest vitamin D, there's a much increased risk with those with lower vitamin D for both cardiovascular disease, cardiovascular mortality, and stroke in those who have low vitamin D compared to high vitamin D. And that's, it's not a small study. This is like over 65,000 participants. This is a study from Argentina that shows if you're admitted to their coronary care unit, okay, this is your risk of mortality, cardiac death, and sudden cardiac death in patients admitted with chest pain in northern Argentina, dependent on your level of vitamin D, right? So if you have a level of vitamin D, which is in this quartile, right, which is around 12 nanograms, then your death rate is actually, you can see, significantly higher than if your vitamin D is anywhere around this. So simply having a low level of vitamin D when you're admitted on the day with your chest pain to the coronary care unit will determine your outcomes. And again, this separation of curves actually is more, I think, impressive than thrombolysis even. This is mortality, overall mortality, serum vitamin D levels, you can see as they fall. And the cutoff here is really around about 20. Anything less than 20, you can see markedly increased mortality ratio. Practical matters in terms of vitamin D. So timing is everything, okay? So if we give vitamin D, first and foremost, what I want you to take away is don't give calcium, right? That's got 400 or 800 units, international units. You need to be giving, on average, most people need 4,000 to 5,000 units a day, okay? So in order to give that, you need to give high doses. But the other thing, this is a study actually published from the Cleveland Clinic, showed that many patients treated with vitamin D failed to achieve an adequate serum level of 25-hydroxy-D, despite high doses of ergo and cholecalciferol. So in this particular study, all participants not responding to treatment were told to keep taking their usual vitamin D supplement, but to take it with their largest meal of the day, usually dinner. So most people, when you say take vitamin D, they take it in the morning, right? But if you simply just ask them to take it in the evening with their dinner, well, look what happens. This is D3, 1,400 international units per day, 28.9, and it went up to 45 nanograms. If you were taking 50,000 international units per week of D2, it went up from 31 to 48.3 nanograms. 57% increase just by asking the patient to take their vitamin D in the evening with their meal. Toxicity is something we always worry about, and we always say, well, we don't want to give more than 1,000, 2,000. But actually, if you look at the circulating levels of 25-hydroxy-D, you can see that we've got a huge amount of redundancy in that you can give up to 10,000 international units per day, and you get absolutely no increase in circulating 25-hydroxy-D, in terms of dose dependency. Really, it's when you get above that you start to get toxicity. So to me, it's perfectly safe to give 4,000 or 5,000 units a day, because here you'll be sitting in this range here, which is perfectly safe. So yeah, so there is a formula that's been worked out, but on average, you will get an increase from, say, if you start with a level of 20, it will go up to about 35 nanograms. Yeah. 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 I don't know. I have, there's a paper I've got somewhere, actually, somewhere I've actually written it down. I've got a formula that'll tell you that. I'll show you later. Yeah, yeah. Yeah. How long? Forever. Honestly. So what I do is I dose them. I give them a kind of a loading dose, and then I maintain them. Because the problem is if you stop, it just comes down again. And in fact, oh no, this is actually just a nice little letter that I got. It's, as physicians, we never get thank you, do we? Huh? And this is actually, to me, I've been treating people with GLP-1 agonists, with insulin for a long, long time. And nobody ever writes a letter to me to thank me, right? Except this one patient, honestly, type 1 diabetic patient, right? Jane, right? She was one of my patients. And honestly, I used to think she was miserable, this lady, right? Used to come in and never have a smile on her face. And I started giving her vitamin D, right? And then she actually, honestly, it's amazing. She wrote to me. So she said, my life has improved enormously since starting treatment with vitamin D. This affects both me and my family. Here are some of the very significant benefits. And she actually went on and listed, had difficulty thinking straight. I'm able to think straight. I'm much stronger and can do a lot more physical activities. It had been a struggle. My children now have a mother who can think, play and chat in the evening instead of just sitting. Can now, this was the best thing, the husband came in and thanked me for this, yes, can now iron for as long as needed. A lot more than 30 minutes it used to take for my legs to become. And it just goes on. So this is just, this is non-evidence based, but there is a real tangible benefit that you see in patients. Thank you.